Hello, everyone. My name is Rachel Guy. I am a trainer. My background is in physiotherapy, and I currently specialize in training females. And on the call today, I have my really good friend, Shannon Brenton, who is a clinical naturopath and nutritionist. And we're going to talk today about polycystic ovarian syndrome because it is something that is definitely mismanaged and it is something that is very misunderstood. So, in case you missed it last week, Shannon and I actually ran a webinar on obesity. And when we talk about obesity, we're not just talking about those who are clinically obese, we were talking about those who are actually moderately overweight as well. And some of the topics and areas that we're going to cover today were also covered in the obesity webinar. And so if you haven't already seen it, I highly recommend that you check it out, and I will post the link below. So, hey Shannon, introduce yourself. Tell us about what you do. Just give us a little bit of an intro to your background, and your clinical history, and what you do.
Sure. Hey Rach, good to see you again. And I guess the easiest way to explain it is for the last, probably 15 and a half years now, I've worked as a clinical nutritionist and naturopath, as you've just told everyone. My area of expertise has sort of shifted over the years. To begin with, really my main passion was chronic disease, and that's really where I've taken the bulk of my time. Of course, that's where PCOS also sits, but I run between treating chronic inflammatory dysfunction all the way through to human performance. So it's a fairly wide field. Do a lot of work with athletes, but really my passion is the everyday person. I treat around 55 to 60 women a week. Have done that now for the 15 years. So women are very much my passion and where my skill set mostly lies. And yeah, excited to be here chatting to you today.
Awesome. So PCOS, let's just get right back to basics and strip everything right back. Polycystic ovarian syndrome, what is it? And tell us how it's diagnosed. What are the symptoms? Give us an introduction to exactly what this condition is.
Sure. Look, first of all, the thing that needs to be said is that polycystic ovarian syndrome is absolutely 100% a different condition to polycystic ovaries. Polycystic ovaries, or the word poly, is just a process of referring to multiple cystic formations or growths on the ovaries. And so one can have polycystic ovaries without having polycystic ovarian syndrome. The problem is with this condition, Rach, and to everyone listening, is that it's a really, really, really complicated female endocrine disease. And this is where the problem lies. You've got what I think statistics at the moment are in between 10 and 15% of women of reproductive age which suffer with this condition. It's supposedly 70% of women who are currently undiagnosed, which says a lot about the mismanagement and the lack of diagnostics around the disease. And really the big problem here, and it's really where I feel very sorry for, number one, the patient, and also number two, the poor old GP that has to deal with the complexity of these upon initial assessment, is that very few women present with the same symptomatic issues. So it's not like, say irritable bowel syndrome, for instance, which once again is an abnormality in itself, but it's not like IBS where you come in with, bloating, alternating constipation and diarrhea, and out comes the IBS stamp. The drama you have with polycystic ovarian syndrome and polycystic ovaries is that once again the symptoms can be everything from not menstruating whatsoever to menstruating too regularly, so what we call oligomenorrhea, or spotting between cycles. Some girls get pain, some girls don't get pain. Some girls have really, really good periods, but then all of a sudden find when it comes time to want to conceive that they can't have a child. And so once again, infertility factors into this condition. So really, I guess to just explain the difference between the two conditions, polycystic ovaries is the formation of multiple cysts, up to sort of 12, 13 cysts on each ovary. And I'll get to what that does and why it's an issue later on. And polycystic ovarian syndrome is exactly the same thing. The etiology or the underlying causation is different. Now, both of them come from positions of generally relative hormonal imbalances. Generally, there's a relative estrogen to progesterone imbalance, not all the time though. Sometimes there's issues with prolactin and thyroid dysfunction, and various things can form the issue that underpins PCOS, hence why the diagnostics for it becomes quite complicated, because a lot of the time, a savvy doctor or an endocrinologist that will look into these things will really have to rule out a multitude of other things that could be the problem at the time. So the thing, however, that will differentiate PCOS for the patient is that the symptoms become more pronounced and in many ways invariably different. So polycystic ovarian syndrome is underwritten, experts say most of the time. I know a lot of people, including myself, that say all the time, always underwritten by some degree of insulin resistance. There may or may not be some level of familial history here and genetics involved, but I find that every time in PCOS, whether they're presenting with insulin resistance at the time, or whether it's an effect of having the PCOS over a period of time, that insulin resistance is always a player. That completely differentiates PCOS from polycystic ovaries in itself. And due to the insulin resistance, we get a really significant rise in male sex hormones, mostly testosterone, and the result of this is that women start to show exaggerated signs of male sex characteristics. So things like excessive hair growth and acne are probably the major ones, excessive weight gain, particularly viscerally around that stomach region, which probably affects most of the time. I'd say 60–65% of women with PCOS will present with that weight around their belly that they just can't get rid of. And sometimes, it can be quite extreme to the point where women will, start getting, mood dysfunction, aggression and depression and anxiety and whatnot, which obviously, for doctors is, quite an easy thing to just say, here, take a pill for an antidepressant and off you go. But it's really a very complicated arrangement, and therein lies the problem in its diagnostics. So getting to the diagnostics itself, because even though I've just described it as complicated, it really isn't that complicated. So, the diagnostics is quite simple. Number one, any woman that would suspect themselves of having polycystic ovarian syndrome, so either showing those male sex characteristic signs, showing or knowing that they have signs of insulin resistance, which we can highlight again fairly soon, or having obvious menstrual irregularities, there's two things that need to be done. The first thing that would need to be done would be an ultrasound of sorts. So it's either going to be just an abdominal or a transvaginal ultrasound, obviously looking for the fact that we do have these cystic formations on the ovaries. That's really the easy part. Once we know there are polycystic growths, then it's about looking for that underlying causation. So this is where a thorough set of bloods becomes really, really important, and we can discuss bloods in 20 minutes or so if you'd like to, if people would like to know what they should get tested. But the bloods in many ways become a kicker that show, number one, do we have the elevated male sex hormones? Number two, do we have insulin resistance? And then depending on how those bloods come up, a woman would want to be looking at having a glucose tolerance test, which would confirm the fact that she does in fact have insulin resistance, and that is in fact the spot that she needs to work in order to get herself corrected.
One of the things that I found in clinical practice, and we've discussed this in person before, is the fact that more and more women now are becoming diagnosed with almost late onset PCOS. So in my practice, I deal with a lot of ladies who are perhaps 27 to 40 years old, and a lot of them are being diagnosed around their mid to late 30s. Now, I've also noticed that there is a correlation between those who are being diagnosed, past 30, and they have a history of yo-yo dieting. So going back to what you were saying about PCOS being a hormonal disease, if you like, do you think that there is a correlation in what you've seen as well between yo-yo dieting, perhaps like downregulation of the thyroid, and some form of insulin resistance because of previous crash dieting and low calories and binge eating, and the correlation of late onset PCOS?
It goes without saying, Rach. Absolutely. I think there's three major things that age brings to the table. The first one is obviously more time for pathology to arise. The second reason is the fact that, in this day and age, it certainly wasn't the case, 30, 40 years ago, but now you don't really find too many women that haven't had a use or a level of abuse, despite the fact that's not necessarily the way many would look at it, of the oral contraceptive pill, which of course will mask symptoms for many years. And then yes, of course, the fact that particularly now as time goes on and people become more and more obsessed by the way they look, yes, the metabolic adaptations processed through constant crash dieting is a massive concern. And yes, thyroid becomes very involved in polycystic ovarian syndrome. The thyroid stimulating hormone itself correlates very correctly with prolactin levels. And prolactin, of course, is downregulated by dopamine. So a lot of the time we find people who have got history of depression will have a higher likelihood of elevated prolactin based on the fact their dopamine's low. And, there is most definitely a strong correlation between thyroid and infertility, and there is most definitely some level of correlation, not as bad as infertility, but between thyroid and polycystic ovarian syndrome. But, you make a really valid point that I think any time a person, tries to live on a very low calorie diet for a long time, or has that history of up and down, weight gain, weight loss, most definitely it puts an enormous load on the gastrointestinal system, the liver, and in turn, when the liver and the large bowel aren't working appropriately to clear estrogen, now we, are more likely to get estrogen dominant disorders, of which in many ways this can tend to be due to low progesterone levels.
Okay. Well, let's get on to talk about PCOS and nutrition and, the common mistakes that people make, because again, like I see it all of the time, whether it's for the purposes of weight loss or because clients or patients have been told to control their diet, they do tend to refer to the calorie counting, very low fat, low calorie, low carbohydrate diets. And these are common mistakes that I see. Like, what are the other things, like the big common mistakes and I guess the myths about, how you should eat when you have PCOS? And, what should be the foundation of a good, nourishing nutritional plan?
Look, the calorie counting approach is completely ignorant, and you and I know this, as would many other people listening to this. But I guess the issue here is that it's very difficult to hold people responsible for being ignorant when the wrong information is consistently being proliferated amongst health professionals out there, particularly in the medical world. So, people can only do and people can only work with what they're told to work with. So a lot of the time, people are always hopeful, and I work with over a couple of hundred women a month, and the poor buggers sit here in front of me, Rach, and are just really overwhelmed, extremely low emotionally, and why wouldn't they be? No one wants to feel that way. Everyone wants to look and be their best. Everyone's got pride in what they show the world, and so I think a lot of the time the reason why people start to run down those roads is based on the fact that they're desperate. So I've got a really soft approach with these sorts of people, because I realise that no one would do something dumb to their body if they knew otherwise. So I just wanted to get that out of the way before we continue. But at the end of the day, I think that probably the greatest myth with polycystic ovarian syndrome lies in the treatment of insulin resistance. And just before we go on, I'll quickly just help people to understand what insulin resistance is, because it's a term that's thrown around out there a lot these days, and everyone's sort of aware of it, and everyone's heard of it, but not a lot of people understand its complexity or its relevance to polycystic ovarian syndrome. So basically, just so people can understand, if we get 100 grams of let's say brown rice, so let's take a relatively low glycemic, high fiber-based complex carbohydrate, and then on the other hand we get 100 grams of sugar. Now let's just take normal old table sugar, which is 50% glucose, 50% fructose, but it's still relatively now we've got a really high glycemic carbohydrate. Now, at the end of the day, both of those will supply us 4 calories per gram. So 4 by 100, of course, is 400. So we're essentially getting 400 calories from that food. Now, the theory goes that if one is ingesting, predominant amounts of low glycemic carbohydrate, that the effect on our blood sugars are stable. Now, that makes complete sense in people who aren't insulin resistant. The problem with insulin resistance, and let's please acknowledge the fact that insulin resistance is quite possibly the largest pandemic of our time. And a lot of it's due to over-commercialization and shit food choices on behalf of us by large food companies that are out there to profit and increase or extend shelf life on their food. So once again, people are making ignorant choices based upon the back pocket of the giants. But The theory goes that if we eat low glycemic carbohydrates, everything will be okay. But what people need to understand is that whether we have a complex carbohydrate or a simple sugar that's a high glycemic carbohydrate, both those things must give us glucose at some point. And so the glycemic relevance is just about how fast that food can supply blood glucose for our body to use. Now, let's please understand that insulin is a hormone, and insulin circulating throughout our bloodstream, looking to bind to blood glucose. And so it's a little bit, I describe it as a Velcro scenario. You've got a little hook bit, a little fluffy bit, and they're basically running around wanting to bind to each other. Now, once that insulin binds to the blood glucose, it will take it inside the cells, use it for energy, and of course the faster the blood glucose gets mopped up, the faster the brain realizes the blood glucose isn't there, and it sends a negative feedback to the pancreas saying, please stop sending us more insulin. Now, in a normal person, that would be the way it works, and so we'd eat a meal, and the glycemic value of that food will either give us blood glucose, now or in, say, 3.5 hours, and the body will produce insulin, and, we'll either have a spike in blood glucose now, or we'll have a steady, increase in blood glucose over the hours that follow, and a nice steady decline, which is, of course, the way we want it. Now, the drama with insulin resistance is that these people are producing insulin just like you and I, Rach. But what happens is that the actual receptor site on the hormone itself is not sensitive enough to actually bind to the blood glucose. So generally, you'll only get a certain level of sensitivity. Let's say, for the instance of this discussion, we've got about 30% of our insulin which is sensitive enough to bind to blood glucose. So what happens is it comes out and it will bind to 30% of the circulating blood glucose from your last meal. But of course, 70% will slip off the insulin and not be recognized, not be taken into the cell where it can be produced for energy. Now, the body doesn't understand the drama. It just correlates the fact that, there was blood glucose, we gave insulin, but we've still got blood glucose. So the assumption here by the body is, well, Rach must have had a really large meal this meal, and so she just needs more insulin. And so the acute phase, response would be, let's make more insulin. So out comes the insulin, which binds to another 30% of the 70% left over. And once again, we're now left with 40-odd% blood glucose left over. Now, your brain's normal reaction to that, Rach, is, well, Rach must be at a party and she's, having, dips and, and mingling and drinking wine and, having sticky date pudding or whatever else it is she likes to have.
I do drink wine, but I drink sticky date pudding just because it's not my thing.
And I know you are guilty of many things, Rach, but that might not be one of them. But at the end of the day, what happens here is that the body has to continue responding to the lack of blood glucose utilization by making more insulin. So at the end of the day, we finally mop up all that insulin, in this case 400 calories of blood glucose. But what happens is that the girl with polycystic ovarian syndrome or insulin resistance has now got 3 times the amount of insulin to the girl that doesn't have the insulin resistance. Now, the result of this is what we call hyperinsulinemia, which just means too much bloody insulin. And the insulin now drives the production of male androgens. So it's due to the high insulin that this poor girl now is producing testosterone at a rate of knots and getting the symptoms of hirsutism, the hair growth, and getting symptoms of acne and symptoms of male sex characteristics. It's all based upon the blood glucose and the lack of insulin sensitivity causing the symptom to rise in the first place. So back to your question, Rach, what's one of the common abnormalities out there in the food world? Well, these women are told consistently to just eat low glycemic carbohydrates. And it drives me fucking mad, excuse the French. And the reason why it drives me mad is that it doesn't matter when you eat that carbohydrate, it will give blood glucose. And if you've got insulin, your problem is the fact, if you've got insulin sensitivity, the problem is the fact that it won't be bound to appropriately at all. And now the hyperinsulinemia becomes a reality for you. So, in insulin resistance, you must cut your total carbohydrate production, intake, I should say. And that doesn't mean you absolutely have no carbohydrate, but if your total carbohydrate intake in a day is 250 grams of carbohydrate, you must cut the total amount of carbohydrate ingested to a lower amount, not just change the carbohydrate to a low glycemic carbohydrate. Does that make sense?
Oh, absolutely. And it's something that I see as a lot of people do come in and they've got they are on 200 plus grams of carbs per day, but they're also on very low fat and low protein as well. And to go from that, where it's actually then not a particularly nourishing diet, you don't really need to necessarily cut everything out altogether, but reduce the amount of carbohydrates that you're eating, boost your fat intake, and be strategic about when you actually eat your carbs. So the best time for somebody with PCOS to eat their carbs would be after training, as an example.
Look, I think you make a really valid point there. That diet you explained of these girls on 200 grams of carbs and low fat and low protein, for instance, these girls are probably having their 1,200 calories, that their trainer or that their doctor or that someone's told them to have. Maybe it's even more. The calories really are insignificant in this point. But the issue that people need to realise is that when we cut our carbohydrates, we need to, by default, boost the other macronutrients to stabilise this. Now, just so people understand, carbohydrate and protein both supply 4 calories per gram. Fat supplies 9 calories per gram, which is obviously why fat has been the whipping boy over the years with stupid suggestions to cut calories. It's obviously the one you want to cut if you're just looking at getting your calories low. But what you ladies on this call need to understand is the fact that protein and fats don't require insulin to metabolize them. So we're not looking necessarily here at boosting your calories any higher than what they currently are. We're looking at changing the types of calories you're eating, possibly to be exactly the same as they are right now, or possibly higher or lower, depending on what you present with. But, I always want to have women rate on the highest possible caloric intake I can, while having, the level of vitality and bodies they want to have. I don't know how you play, but I generally will boost women's calories more than lower them. But in a case where women are on, say, a 1,000-calorie diet, my job is not to spook them. And generally, I would take that 1,000-calorie diet, stick on 1,000 calories, and do exactly what you just promoted a moment ago: pull their carbohydrates back to a healthier percentage of the total, and then increase their proteins to around about, depending on their activity level, anywhere between 0.8 and 2.2 grams per body kilo. And then I boost their fats to generally somewhere between 25 and 40% of their total caloric daily intake. And then the carbohydrate just factors in as the leftover.
I do exactly the same thing. It's something that I'm very passionate about, is actually feeding my girls more and trying to basically boost metabolic capacity. And it's not something that, if somebody presents to me on an 800 to a 1,000 calorie a day diet, which is not uncommon, it's not like I automatically go and then feed them 1,500 to 2,000 calories a day, because then obviously they're going to get fat. So you need to do it very slowly, and depending on how long somebody has been in that state. It may be, I've got some ex-bikini or figure girls who it's taken me 6 months plus to reduce their cardio and to sort of really slowly boost their calories from 800 right up to, they may only still be on 1,400 calories, 1,500, but the quality of the calories is so much better, and they're feeling better. So this isn't an overnight switch to say go from 1,000 to 2,000 calories. It is very much a step-by-step process, depending on what somebody's presenting with.
Do you know what, Rachel? I consistently and regularly use basal metabolic testings in my facility here. I've got an exercise scientist here that uses a really advanced meta-analysis technique and machine to find out what people are actually burning. And I'm still yet to find any of these ladies that you reference that aren't burning a minimum of 1,440 to probably 1,600 calories in a day, and that's sitting on their ass. So how anyone can actually think they can live on 1,200 calories and feel well, or if you've been on 1,200 calories for a period of time and you haven't lost weight, with that, say, 250 to 350 calorie consistent daily deficit, you might like to start looking at the fact that your issue is not caloric.
100%. And not only that, when somebody's on, just as a side note here, this goes beyond PCOS, but that when somebody's on such a low calorie diet, the incidence of binge eating is just skyrockets. So, then we have the introduction of eating disorders as well. So, low calorie dieting and eating well below basal metabolic rate is not only dangerous, it's counterproductive, and it's really something that, unfortunately, still, with all of the information out there, is still the go-to for fat loss, which is such a shame.
And more importantly, in this specific case, getting back to the PCOS, it's not what the woman requires to actually, fix the underlying causation of her concern. So, it's really, a chicken and the egg scenario where, these women a lot of the time, and not all the time, but most of the time that I find have generally got some level of body fat issue. Then again, I'd say probably 30% of women with PCOS that I treat have got no weight concerns whatsoever. But in those women who do have the weight concerns, you've got to start looking at, well, is the weight concern, did it come before or after the actual PCOS? And generally the two of them, they feed each other and they feed each other. Of course, we understand these days that the adiposity itself is inflammatory. And so the more fat you're carrying, the higher rate of inflammation the body's producing, and moreover, the higher the likelihood there is going to be of hormonal disruption from that point.
Let's add in another piece to the puzzle here. Like, let's talk about PCOS and stress, and let's talk about the prevalence and the reliance upon caffeine, how that affects PCOS, and what comes first, again, the chicken or the egg? Is it that somebody is extremely stressed, and again that creates a hormonal response, which then can, I don't want to say cause PCOS, but it can certainly contribute to signs and symptoms.
I can say 100% accurately from many, many years of experience that stress most definitely is a lot of the time the cause of PCOS, due to the fact that stress is generally, once again not always, the cause of insulin resistance. So you've got to start looking at the fact that insulin resistance will come from one of three places. Number one, it'll come from a family hereditary of type 2 diabetes or long-term hypoglycemia or whatnot, but blood sugar dyscrasia is the form. Number two, it will either come from the fact that people are chronically stressed, and with stress we refer to what we call the hypothalamic pituitary adrenal axis, where the adrenal glands are consistently under long-term caning from the fact that the body's consistently trying to down-regulate its stress levels and its inflammation levels through too much long-term stress. And the problem with stress, Rach, is that not a lot of people know how to actually put their finger on what stress is. Mm-hmm. And too many people say, oh, no, I'm not stressed. And that's only because of, once again, the level of adaptation they've incurred in their life. So, I use my particular circumstance with lots of my patients, and I say to them, I've got 3 very young children, all under 5. I've got 2 companies. I've got a wife at home currently with glandular fever. Do you think I'm stressed? And they say to me, oh, yeah, of course you are. And then I'll say, well, you know what, I don't necessarily feel stressed because it's just what I have to deal with on a day-to-day level. So my body has adapted to the fact that that's my circumstances. However, if I give you my 3 children, my 2 companies, and my Epstein-Barr virus-clad wife, no doubt you're going to be pulling your hair out for the months that follow until you too adapt to those surroundings. So stress is adaptive, and I think that it's very difficult for people to often know when they're in that stress state. So at the end of the day, though, the production of long-term cortisol through the adrenal glands most definitely will cause insulin resistance. There's been many, 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 many studies that correlate the relationship between cortisol and insulin resistance, the relationship between cortisol and thyroid dysfunction, the relationship between cortisol and obesity. Seriously, I'd rather people smoked a packet of cigarettes a day than just stressed a lot. And I know that sounds like a very strange thing to say, but just for a good smack in the face, everyone looks at cigarette smoking as the enemy. I'd like to say that stress is probably worse than that.
I 100% agree, and there's a great book actually. People are interested. There's so many books that I've read on stress that are fantastic, and I think my favourite one that's been quite entertaining as well is by neuroscientist, I believe it was. His name is Dr. Robert Sapolsky, and the book is called Why Zebras Don't Get Ulcers. And it's such a fantastic book. And it's
is that the same as Why Zebras Don't Get Ulcers?
Yes, is that a British way of saying maybe we say zebras? I don't know.
Sorry, Rach. Sorry, everyone. I couldn't help myself.
I speak to so many American people, I'm sure they say zebras.
They do. Sorry, continue.
But, let's talk about, we've talked about pieces of nutrition, stress management. What about training? So one of the common questions that I get asked a lot is, okay, I've been diagnosed with polycystic ovarian syndrome. I've got very high testosterone levels, therefore I can't lift weights because I'm going to get muscly, manly, and big. How incorrect is this?
Well, we all know that's crazy. I've lifted weights for 22 years. You know, it's not that easy. You know, look at you, Rach. You're a fine example. You lift weights. You're a big compound lifter. You do all those sorts of things. You know, you're still feminine. Yes, you've got great muscle tone, but you still look like a girl, right? So I find that yeah, that's just another ignorance, and that's just, you know, people being stressed about it, and I fully appreciate that. But the reality, obviously, is very different. And any of those girls out there that, you know, are enormous and muscly are probably living on Anavar or some kind of other, you know, significant anabolic, you know, steroid that's making them be that way. And you know what, that's their choice, and they're probably doing it for competition reasons. But I think that it skews the opinion of the average female who's trying to make a decision about how they'd like to live for themselves.
I've got 2 points to make here. I think the first one is that even if you have got high testosterone levels for a female, you still have nowhere near the amount of testosterone that a man has. That's the first thing.
True.
The second thing would be that the best way to manage insulin resistance and actually help yourself is by lifting weights.
I would agree, absolutely. And it's a really good way of dealing with stress management, of course, you know, as we both know.
Absolutely. And again, fat loss, you know, I'm a big believer that cardio is important, but I'm not a big fan of long, slow duration cardio, particularly fasted cardio, first thing in the morning if you're spending an hour on the treadmill every morning. Not only is it counterproductive, it is also very stressful to your system. It's stressful to the body. And you've got to realize that, like we've just talked about, stress comes in many forms. It could be family stress, as in Shannon's situation. It could be financial stress. It could be nutritional stress from underfeeding yourself, eating poor quality foods. It could be that you're overfeeding yourself on poor quality foods, or actually, if you're overfeeding yourself still on good quality foods, like that's a stress on your digestive system. So stress comes in many forms, and as always, unfortunately, this is a really unsexy thing to say, but it comes down to balance and bringing yourself back into a balanced, normal, I don't think normal either, but a balanced lifestyle. And if you're wasting 5 to 7 hours of your week running on the treadmill in the hope to lose body fat, you're going about it the wrong way.
Well, look, I find balance extremely sexy, Rach. I might be the only one, but thanks for bringing it up.
All right, well, I do too, I'll confess.
But look, it's a valid point. You know, I think a lot of the time too, you know, when you're talking about, you know, stress management and movement, you know, a lot of it's about trying to, you know, get back into your body out of your head, you know, because a lot of that stress is based on our own internal dialogue, and it's a long-term process of everything from, you know, the inner critic, which is, you know, a part of our greater mind and our subconscious that constantly seeks to shame us for not being perfect. But a lot of the time, you know, that process of mindful movement, which is, you know, what myself and my exercise scientists here describe, you know, movement as best being, is a process of, you know, consciously being in your body at that moment, which comes back into that process of mindfulness, you know, which is probably a bit wankier these days than balance is, because it's probably an over abused term all over the place. But people are just, you know, so, you know, affected by how fast-paced the world is now, and people generally don't get a chance to just sit and reflect and, you know, and what I call check in, you know, like, how am I feeling? What's happening for me right now? And what are the emotions around this? And it's funny, you know, even looking at like dysfunction from that of, you know, a practitioner like Louise Hay, that people would probably know, who's very much, you know, into the fact that emotions are tied to physical pathology. You know, Louise Hay said something once, and this is not a quote unquote, and please forgive me, it won't sound near as delicate as the way she puts it, but she says something like, you know, if you've got a condition and there's, you know, an underlying emotive response behind that, the body will not possibly allow for that condition to be alleviated or ameliorated if it's a functional component of your personal progression forward and your own evolution. Does that make sense?
Yeah.
So, you know, I find for me, like you talk about weights, you know, I do my weights in the gym like anyone else, you know, and I love that component. But 2 or 3 days a week, you know, I get out in my local area here and go bush, you know, and do bushwalking and just try to get to a place where I can really be inspired by my surroundings and have that emotive check-in time where I want to sort of see how my week's been, and am I holding any grudges, and how do I feel in myself, and how's my relationships, and do I have any regrets this week, and just being able to, I guess, have a sounding board somewhat, with the universe where I can let go of some of my stresses. But I call it checking in, and I do it consistently because I find it's just a really nice way of consistently knowing where you're at, and consistently being able to, wake up tomorrow morning and put your foot on the floor without yesterday's shit dragging you down.
100% agree. And, we all live in a very fast-paced environment. I'm exactly the same, working 70 plus hours a week in my business, trying to train and, stay in relatively decent shape year round. And one thing that is, that is really important in my long-term success is that ability to just check in. So every day I go for a walk, whether it be 15 minutes if I've got no, I say inverted commas, no time, or, I prefer to go for an hour. And during that hour, I sometimes listen to podcasts, or I don't listen to anything at all, and I just walk. And quite often I sometimes have my best business ideas when I'm out and about and not thinking of anything in particular. But it's a really important time for me, and I do find that if I don't have that time, my stress is, I guess, comes out in the form of I have quite serious or chronic IBS, and I end up with a very seriously bloated tummy, which can last for weeks and weeks and weeks if I don't take a good hold on my stress management. So checking in is a really important point, and I'll definitely put that in the show notes here. It's critical, really, whether no matter what ailment I guess you're dealing with, whether it be obesity, PCOS, trying to improve your sleep patterns. It could be anything. It's a really important point. And just
when you've got a male practitioner also discussing something of such a yin topic, take notice, because I'm not trained to think that way, and I'm not trained to be that way, and that's just been through many, many, many years of seeing things being not addressed, I guess, through Western technique and Western mindset, that I've had to start looking outside the square, and that's for the sake of the people that I'm dealing with, and whether it's a male in front of me or a female in front of me, it's of complete relevance. But I guess just getting back to PCOS, for the ladies on the call, I said that I'd discuss very briefly, what they should have checked, and look, I want to just acknowledge that the majority of people listening to this already probably have PCOS, so for them it's been diagnosed and they know where they're at, and that's all good. So for those girls, here's what you need to consider. The first thing is obviously getting your androgens or your testosterone levels down, if this is in fact an issue for you, which generally it is in most cases. I use a Chinese herbal medicine called penny and licorice combination, which just works a treat, and it's got many, many, many clinical trials which validate that it does reduce testosterone. So I don't take it myself for obvious reasons, but I've used it successfully lots of times with women in polycystic ovarian cases, and have also, just because I'm a fairly chronic researcher, and even just looking on blog sites at women around the world, who have used this formula, that have noted, anywhere between, 30 and 100% reduction in signs of male sex characteristics. So getting significant reductions in acne, significant reductions in, in hair growth, and also starting to get an increase in hair growth on their head. So this is two things happen. You tend to grow hair places you don't want it, and they also tend to get thinning on their scalp. So I've seen significant issues. That's the first one. The second one is to do with any known underlying issues. So if you've had your FSH and your luteinizing hormone checked, well, if we know there's dramas in either of those places, there's specific treatment, and I'm happy to help anyone with that who has issues that'd like to contact me directly. And certainly looking at estrogen levels, I generally recommend a 2, 4, and 16 hydroxyestrone study, just to make sure that the non-proliferative protective estrogens, which are the 2 hydroxyestrones where they need to be, and the 4 and 16 hydroxyestrones are low. But if any of you ladies are getting issues, particularly premenstrual, any of those classic PMS symptoms, sore boobs, low back ache, irritability, breast distension, cravings, mood dysfunction, whatnot, that's generally a fairly good sign that the liver is not able to clear estrogen appropriately. And I generally will use some kind of progesterogenic treatment in order to balance that estrogen progesterone out. Once again, I can help people with that if they'd like, because I use practitioner-only formulas that I can't discuss on this webinar. But they're the two things you do to deal with the underlying hormonal imbalances. I highly, highly, highly recommend dealing with the stress. And, like we talk about checking in, which is, for me, really it's the same thing as meditation, but doesn't requiring us sitting down going for an hour, And in a busy world, where you're trying to give people realistic things that they can do in their life, I would really recommend checking in. And, what part of that checking in process is actually, sitting in that moment and asking yourself how it is this condition makes you feel. What are the emotions which underpin it? Is it anger? Is it sadness? Is it overwhelmment? Is it, feeling stuck? Is it fear? What might it be? Because a lot of the time it gives us a really good opportunity, and disease generally gives us a really good opportunity for personal growth. So that's a bit off the beaten track, but I'd highly recommend that. Definitely look at gastrointestinal function. It's a really important part. There's an old naturopathic philosophy which says, when in doubt, treat the gut. And I didn't really quite understand that until I'd probably consulted full-time for 7 or 8 years, where I was able to consistently correlate, disease and dysfunction with poor gut health. Mm-hmm. So, even little things like the metabolism of estrogen, probiotic supplementation is really, really, really important here. People who have got too much dysbiosis, or not enough good bacteria to bad bacteria, we start getting a reconjugation or a reactivation of estrogens once they've actually been processed through the liver before they're cleared through the bowel and through the kidneys. So, making sure that, we've done regular detoxes. I'm a massive fan of detoxification. It's a bit of a wanky term these days, and I think that too many people look at detoxes as all the same. The fact is they're not. The lemon detox diet is not a detox, okay? I'll just throw that out there right now. And most of the detox things you find sitting on health food stores or in chemists are probably not going to be appropriate for a lady with polycystic ovarian syndrome. But I highly, highly, highly recommend doing a really thorough, complex gastrointestinal detox and liver clearance. Makes a really, 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 really big improvement. And there's lots of anti-estrogen things you can take, like diindolylmethane and indole-3-carbinol and broccoli, and lots of things that can be used if you know you've actually got an issue. Once again, for the sake of this webinar, I want to leave those specifics because they're not specific to everyone. But making sure your gastrointestinal health is bang on. So if you're getting any symptoms of upper gastrointestinal dysfunction, so heartburn, reflux, bloating, hiccups, burping, or any lower gastrointestinal complaints, so lower abdominal pain, lower abdominal bloating, constipation or diarrhea, I highly recommend that you look at getting these things sorted with a health practitioner. I'm happy to help people on the side too if they'd like. There's no dramas there. And if everything's good as far as and you've been checked and there's actually not been any clinical prognosis of what's going on, or diagnosis, I should say, of what's going on, my suggestion is get a more thorough check, because polycystic ovarian syndrome is something that tends to fly under the radar a lot of the time. Looking for insulin resistance, it's not good enough to just check fasting blood sugar. And this is the greatest stuff up of modern medicine that I see with GPs now, that when people go in and they're looking for if they've got a blood glucose dysfunction, the doctor checks their fasting blood sugar levels. 9 times out of 10, your fasting blood sugar levels will be okay, but you've got to understand that in the early to moderate phase of insulin resistance, your blood sugar is always going to be fine because your insulin's about 10 times bloody normal. So you must do a fasting insulin test, or you must get the glucose tolerance test done. So if you do go to your doctor and get a blood sugar test done, please ask them to check your fasting insulin as well as your blood sugar. Very, very, very important. So hormones to be checked: luteinizing hormone, follicle stimulating hormone, full hormonal assays, so estrogen, progesterone. We need to get testosterone checked, both as our total testosterone and also our free testosterone, and we also need to get our sex hormone binding globulin checked, just to make sure that it's within normal realm, because a lot of women with polycystic ovarian syndrome have actually got quite low levels of sex hormone binding globulin, which means that even if their normal testosterone levels are quite normal, and the doctor hasn't checked their free testosterone or their free estrogen index, what happens is, because of the low sex hormone binding globulin, it doesn't bind the testosterone enough, and we've got too much free testosterone in the bloodstream, even if it looks normal on paper. So it's really, really important that those things get checked. Other than that, it's a simple ultrasound, just to look and to identify that we have the cyst there. And another thing I didn't say too in the diagnostics rates, not always, but a lot of the time, through bloods you can diagnose it even without having the ultrasound, because generally you'll find that the luteinizing hormone will be sort of 2 to 1 or even 3 to 1 over the follicle stimulating hormone, which outside, right on ovulation is a very strong abnormality for women. So most definitely worth being checked, all those parameters. Getting back to just going through the diet, ladies, cut your total carbohydrate. So I personally wouldn't ingest, if I had moderate to severe polycystic ovarian syndrome and I had diagnosed insulin resistance, I personally would not ingest any more than 50 grams of complex carbohydrate per day. I'd possibly even cut that back. I'm an enormous fan of ketogenic diets in the early phase of polycystic ovarian syndrome, but not for too long. You can go horribly wrong with ketogenic diets for too long, but I find that if I've got a lady that comes in who's in really bad need and quite significant dysfunction, I'll put her on a ketogenic diet for probably 4 to 6 weeks. Then I'll bump her carbs up to more of like a modified insulin zone regime, which I personally find works really well. Like I said, with the protein, I'd have protein anywhere between 0.8 and 2.2 grams per body kilo. So for the ladies listening in on this call, simply get a calculator, multiply your current weight times by the amount of protein you require. So 0.8 would be for someone who's sedentary. So if you do nothing, multiply it by 0.8. If you're a person that walks the dog or goes swimming in pools or just generally chills out, might do the odd body pump class at a gym, my suggestion would be to go to about sort of 1.2, 1.3 grams per body kilo. If you do lift any weights, like you all should be, I'd be going between 1.5 and probably 1.8 grams of protein per body kilo. And if you're more like the Rach of the world and you do like to lift regularly and you really require that appropriate tissue repair from going hard regularly, I'd be looking at going anywhere between 1.8 and 2.2 grams. So once you've worked out how many grams of protein you need, and you have then worked out that your carbohydrates need to be no more than, say, 50 grams, which is 200 calories, you then will work out exactly how many calories you're getting from the protein. So once you've worked out you need 120 grams of protein, multiply that by 4. That will give you the amount of calories it is. You can add the 2 calories together of your carbohydrate and your protein to get a total caloric ingestion from those 2 macros. And then what you need to do is factor in your fats as the leftover in this situation. So, if you're getting, say, 700, 800 calories from your protein and your carbohydrate total tally, and you want to sit on 1,200 calories, well then obviously you'll require the leftover, which will be generally around 400 to 600 calories depending on your intake of fat. Now fat's 9 calories per gram, so you need to divide that by 9 to get the amount of grams of fat you should be ingesting. And this is where types of fat become really important as well. So you ladies are going to want to really have a high prevalence of your anti-inflammatory fats, so your essential fatty polyunsaturated fatty acids. So your fish oils and your flaxseed oils should really factor there as some level of supplement. I'd really recommend a teaspoon of a high-strength liquid fish oil twice a day. I'm an enormous fan of really getting those fish oils right up. Using a high-strength liquid fish oil is the equivalent of about 23 fish oil capsules. So unless you want to swallow fish oil capsules of that amount, make sure you use the liquid. I would then be looking at bringing in my either my conjugated linoleic acids or my medium chain triglycerides. So I'd probably be, just for legalities in this country, either using MCT oil, which you can get under the Melrose brand and various others, or I'll be looking at using coconut oil, probably to the tunes of a good dessert spoon a day. And then on top of that, in the middle would be those monounsaturated fats, which come from your nuts and seeds and avocado and olive oils and et cetera, et cetera. These fats should not be heated, ladies, just like the polyunsaturates. But these ones here can be used for salad dressings, or you can obviously eat nuts and seeds for snacks during the day. Polyunsaturates also should never ever be heated. And just to save me having to regurgitate this again, I've got a video. If you go to askshannon.com.au and look up my video on fats, you can get all the information you understand about fats and what you should cook with and what you should avoid cooking with. But once you've done that, you've got really pretty well a nice structured program, which without having to fork out your cash to see someone like myself will most definitely put you on the right roads to recovery. And I will put my life on it that within 3 to 5 weeks, probably within 2 weeks, but within 3 to 5 weeks, you will feel so much better. Your blood sugars will be stable. As a result, your energy will be stable. Your cognition will be great. You'll actually be able to remember everyone's names and where you put your car keys. And what you're doing is actually driving down your inflammatory markers here and giving your body forms of fat that it wants to use as a preferred form of energy when it doesn't have enough carbohydrate. So now it puts your body into a scenario where it wants to burn fat rather than carbohydrate. That's an amazing thing because 3 things happen. Number 1, you burn fat, which means you burn 9 calories per gram. You burn fat, which is great, so it comes off your bum and your hips and your thighs and anywhere you're storing it. And you generally you generally will preserve your protein levels, so you're not going to eat into your stored muscle mass, which is a terrific thing when you're trying to avoid the aging process.
Just to quickly add in here, like, what are your thoughts on gluten and dairy and PCOS? I mean, do they play a major role, or is it just something that you would remove out of somebody's diet if they were actually intolerant or allergic to them?
Look, things like methylxanthine, so Coca-Cola and coffee and these sorts of things should be definitely minimised. People can Google that if they want more information. Gluten's just a horrible, insidious little protein that is generally quite difficult for people to absorb. Really, there's 2 sides of the gluten debate. You've got those of the world that say, don't be silly, it's just a thing, it's okay. They're generally the people that don't have any issues with their health. And then you've got, the people on the other side that find, that, I've got issues. And things like psoriasis, for instance, very closely attuned to gluten intolerance, obviously celiac disease and, IBS and these sorts of things. But I can tell you right now, Rach, I'm yet to see a person, and I started this way in the performance world, working with, some very, very high-end athletes, taking athletes predominantly off gluten and just finding a significant increase in their rate of recovery and performance. That was probably 7-8 years ago now, and in 7-8 years since then, I typically take most people off gluten these days because I typically find that most people just feel better without it. Yeah. The end. So, gluten's one of those things that's not adding to your life. I think the mistake people make coming off gluten, though, is they cut their gluten out, which means they cut out bread, pasta, et cetera, all their flours, and they don't replace it with other carbohydrates. And so generally they end up cutting their carbohydrate calories too low, and they feel ordinary because it takes a few weeks for the body to get into a process where it can burn fat as an efficient form of fuel when it's been used to burning sugars for so long. The dairy thing, I'm not a big fan of dairy, and it's not necessarily because I'm a hater of dairy. It's generally because of the way dairy is produced these days. You go back to, when our grandparents were kids and you were pulling maybe a litre or 2 of milk a day from a cow. These days they're pulling, upwards of 12 litres of milk from a cow, which means that poor cow is generally getting, dramas with mastitis. Rather than resting the beast, they just pump it full of antibiotics while they continue to milk it, and those antibiotic residues now go into your milk. So, when you're starting to look at female hormonal dysfunction, you've got to take a strong opinion in the role of environmental estrogens in the prevalence of these disorders. And so when you're looking at, estrogens through food ingestion like that, when you're looking at the internal linings of cans that we eat tuna and, tin tomatoes and things from that contain toxics or what we call xenoestrogens, and the bisphenol A's and all these sorts of things that are actually in food production these days. Seriously, the more people can just simplify the way they eat and get back to, eating foods, that come from the food section, not the aisles in the middle that we're told to avoid, the quicker things are. You can, of course, get around the dairy thing by consuming organic milks, and that obviously takes that out. I'm personally just not a massive fan of dairy for a lot of these people. From a Chinese medicine perspective, dairy tends to accumulate damp, and most of these menstrual dysfunctions have a damp element attached to them. So I tend to remove it personally.
Okay. So, Shan, just wrapping up, if anybody wants to work with you, we are based in Sydney, Australia, both myself and you as well. Both of us do work online. So if somebody wanted to book you for a consult, how would they be able to get hold of you?
I do online consults, but I'll be honest, I don't enjoy them. I'm more a face-to-face boy. I find it difficult working with people doing the online thing. The easiest way to get me would just be to email me, shannon@shannonbrenton.com, where I'd probably organise either a phone or a Skype consult. I do lots of those, but I actually do have a website, shannonbrenton.com, where I do online consults, and I've basically created forms that go out to people, and it's all done through a faceless process. And while I still do those, these sorts of situations I prefer to do face to face. And so, a Skype or a phone call would be fine. So yeah, Shannon at shannonbrenton.com. Otherwise, anyone within Australia can ring my practice, which is 0243 684597, and my PA can book appointments on their behalf.
Awesome. And anybody who wants to talk to me about training and basically implementing the things that Shannon and I have discussed today. So it might be that, a lot of my girls go to see Shannon for a lot of blood work and testing, and then come back to me for the actual how to implement things. You can catch me at www.athleticfox.com, or you can email my admin team, which is info@athleticfox.com. So we're going to wrap this up today. If anybody has got any suggestions on any further calls that you want Shannon and I to do on any particular health issues, I think we should probably do one on detoxification, and we'll talk about some of the, some of the diseases and ailments that can be seriously helped by doing a really solid detoxification program. And perhaps also we'll talk on IBS as well. Very close to my heart, so we should probably run.
You're just trying to get a free consult, Rach.
Oh, shut up! I've paid you enough money over the years.
Look, I'm happy to do as many topics as people like.
Sure.
First and foremost, for me, I'm an educator, and I'm fortunate that I've got other businesses these days that I earn money from outside of clinical consultancy. So I'm certainly happy to give time to help people for free these days. So if anyone does have any ideas as to what they'd like, I certainly think detoxification would be a good one, because there's a lot of innuendo around that topic. But thyroid would be a great one. Infertility would be a great one. Throw it out there, girls. Let us know what you'd like, and we can certainly organise it. And it's funny, Rach, just after the obesity one we did a little while ago, I've had a lot of feedback from people who are telling me they're actually turning. I think this one's just an audio, but the last one we did was actually a visual webcam. And I have a lot of people now that are actually turning a lot of these podcasts that I've done into audio and listening to them in their car on the way to work, which I thought was pretty cool. So if you're driving now, hello, be safe, and send us some ideas, and we'll keep you entertained on your drive to work.
Absolutely. I mean, look, I'm going to pop this onto YouTube, but it's certainly one that will be I can see you on webcam here, but it will be, I think, audio only on YouTube. But I think it could possibly be time that you and I started a proper podcast.
Might be good.
Throw it out.
But, anyway, you told me today was audio only, and I'm sitting here in my hoodie. Lucky I did do my hair, but as long as you don't use today's.
Oh, come on! I've just come out of the gym. I've just come out of the gym as well, with my sweaty face and my hair in one of those obscene pineapples, which means that shit is about to go down, or it did go down. Anyway, let's wrap this up there. Shannon, you are such a legend. Thank you for being such a good friend, and also giving your time, helping so many girls. So we really appreciate it. So thank you very much.
A pleasure. Thanks, Rach.
Okay, I'll chat to you soon.
See ya.
See ya.